2, 1. Take it away, sir.
Perfect. So here are some of the objectives for my talk today. First, I want to describe some of the basic principles behind pulmonary gas exchange. I know that gets kind of confusing for folks, so I just want to talk about what are the main drivers behind pulmonary gas exchange. It's really at the core of what we do as respiratory therapists. Then I want to explain some of the steps that are involved in non-invasive pulmonary gas exchange measurements. And so we'll show you just a short video that runs through what that looks like. Then finally, I want to describe two things. First, I want to describe how pulmonary gas exchange changes in disease. And then most importantly, I want to make sure, because this is a technology that is even available in the Philippines, I want to make sure that you're aware of what the limitations are to non-invasive pulmonary gas exchange analysis. A few disclosures that I just want to get through before we get started today. I want you to know that the views that I express today aren't necessarily those of my employers, and that any off-label use of drugs or devices today is for educational purposes only, and it's not intended to be an endorsement of off-label use or to be a change in the indications for use for devices or drugs. And I should say, just as a reminder, I am medical director of Metapines Corporation, and I'm going to be discussing and using some screenshots from our gas exchange analyzer today to help explain the physiology behind pulmonary gas exchange. And so I just want to disclose that potential conflict of interest. So what are the questions that pulmonary gas exchange analysis answers? Well, in a nutshell, in a short period of time, pulmonary gas exchange helps us answer really three essential questions. And that's, is ventilation adequate? Is gas exchange efficient? And is blood oxygenation sufficient? And the place that we look to answer those three questions is the steady state end-tidal CO2 for the answer to whether or not ventilation is adequate. Notice I'm not saying whether it's compensated. But a normal end-tidal CO2, for example, is going to run like 35 to 45 millimeters of mercury. Then we ask ourselves, is gas exchange efficient? And in order to answer that kind of question, we look to the oxygen deficit, which is the difference between the alveolar O2 level that is directly measured and the calculated O2 in the blood. That is the oxygen deficit. We'll get back to this, but a normal range for oxygen deficit in you and I is probably 0 to 10. And when we think about where does the cut point sort of exist for patients that have sort of diagnosed gas exchange abnormality, we're usually looking at something that's larger than 30 or 35 for that. When we finally ask the question, is blood oxygenation sufficient? We receive those answers from what we refer to as the GPaO2. That is the calculated PaO2 in the blood. And we're going to be spending some time today later after we get through some of the basic concepts of pulmonary gas exchange, explaining how it is that that value is calculated. But for our purposes in the hypoxemic operating range, we use very similar cut points to the PaO2 like you would find on a blood gas. That is less than 80 for mild hypoxemia, less than 60 for moderate hypoxemia, and less than 40 for moderate hypoxemia. So here is an example of gas exchange changing over time. This is me, and I survived this episode, but you can see on the left-hand side that my calculated PaO2, again, remember that that's sort of like an analog to a PaO2 on a blood gas, but we're going to talk about the differences and limitations today. 3.5 hours later, my PaO2 is 78. And the question arises, what happened to me in this time frame? And a lot of my colleagues will say things like, you were exercising, you were holding your breath. But everything that we need to know actually exists right here on the monitor. Non-invasive pulmonary gas exchange monitors try to provide us a very wide view, a very detailed view of what is going on in regards to gas exchange. And you may notice that there is this change in barometric pressure here, and there's a change in the alveolar O2 level in the lung. And when we take a look and see what happened, the first measurement was taken. Was taken in a different location than the second, and we'll get back to that in a minute. But when we're trying to figure out what's happening to me here, we can think about the equations that govern diffusion of gas across a membrane. And we know that there's a number of different things that govern diffusion of gas across a membrane. This is a very famous picture. I think it ran in major news articles like the New York Times or the Washington Post. But this is the oxygen masks falling down from the ceiling of an airplane. And the question becomes, why is it that we need oxygen on airplanes? What is the FiO2 at 30,000 feet, for example? Well, it turns out that the FiO2 at 30,000 feet is actually 21%. So the question becomes, if it's 21%, the FiO2 at sea level, and it's 21% at 30,000 feet, well, what's changed? Why do we need the oxygen? We need the oxygen because the barometric pressure has changed. And if you take a look at the first measurement, the barometric pressure is 742, and the second measurement is 630. And that's because my first measurement was taken in Minneapolis, and my second measurement was taken in Denver. And this goes to show that the pressure differentials across a membrane can matter. And here's the alveolar O2 level has dropped from 107 to 81. Now, there's a few other things going on here. They're kind of detailed and probably not worth getting into. There might be some changes in the depth of my breath, or potentially, although it would seem a little bit early, some hypoxic vasoconstriction occurring that makes my lung a little more efficient. Here we see there's an oxygen deficit of 13. Here we see the deficit is 3. That's a good thing, because if I was running through the Denver airport to go ahead and grab a burrito, for example, maybe I would pass out. But my lungs have become more efficient. So rather than having a deficit of 13 and being in the upper 60s for my PaO2, my deficit has dropped to 3. And so my calculated PaO2 is 78. There's a few assumptions going on here, but this is a really good example of how altitude can go ahead and influence our oxygenation level. I want to show this to you because you may have heard during the pandemic, there were a lot of theories about how COVID-19 might be influencing what's going on in the lungs. And every once in a while, it was suggested that what was happening was very much like high altitude. I will be showing you pulmonary gas exchange measurements today that will suggest that this is nothing like high altitude. And in fact, rather than seeing the alveolar O2 level go down, we will actually see it go up. So we know that the pressure differentials matter for diffusion of gas across a membrane. The partial pressure of that gas certainly matters. That is to say, the barometric pressure reduces. And so 21%, and just to back up for a second, 21% of 742 minus the water vapor pressure, which is roughly 47, and 21% of 630 after you subtract out the water vapor pressure, pretty much accounts for this reduction in alveolar O2. But if that were the only thing governing diffusion of a gas across a membrane, I pose another question. And in this hypothetical, and I should just say that the image on the left was taken from an article published in The Lancet in 2019, but you're climbing up a mountain. And as you're climbing up a mountain, and this mountain happens to be, we'll just call it Mount Everest, you realize that you're not the only one that has decided to climb up this mountain. And in fact, you realize there is no way that you're going to summit the top of Mount Everest in the window that you've been allotted. In fact, you're going to run out of oxygen. And as I say, in your last minutes, as the world sort of starts to encircle around you and you realize that you might not make it off this mountain, you look over and you see an eagle. And that eagle is just flying by, and you ask yourself a fundamental question. You say, why is it that that eagle doesn't have as hard a time breathing up here as I am? And you might ask yourself, it might be very common to think, well, maybe there's just some basic adaptations. Maybe it's just taking larger tidal volumes, or maybe it's changed its red blood cell count to accommodate for altitude. All of those are very good guesses, and some of that does actually occur in certain birds. But actually, there's something much more fundamental going on here. So why is it that birds don't have a harder time breathing at altitude? Well, it turns out that birds don't have a diaphragm. And they don't have a diaphragm for a reason. They don't have a diaphragm because they have an ultra-thin capillary membrane. That is to say, the distance that the gas has to travel is very reduced. When we talk about diffusion of gas across a membrane, we say it is inversely proportional to the thickness of the membrane, which simply means the thicker the membrane, the lower the diffusion, or the slower the diffusion might be the accurate way to sort of view it. And because of that, birds have sort of an air entrainment style system that doesn't require a diaphragm to move air in and out, because if it did, the negative pressure that is created in the space between the chest wall and the lungs would literally potentially shred their lungs. And so this is one of the reasons why they're able to go ahead and tolerate these lower partial pressures of oxygen. So you might ask yourself, okay, we know that there is the factor of the pressure of the gas. There is the factor of how thick the membrane is. But what else is at play here? Well, one of the questions that you might ask yourself, or that folks often ask, is how does CPAP actually improve oxygenation? We have a picture of these collapsed lungs here, and there's actually a very nice video which we may show you as part of this. But as the lungs expand, they have these areas of atelectasis, and as we turn up PEEP, or positive pressure, you can actually see those areas of the lungs start to expand out. And that increases the surface area for which gas exchange takes place. So there's sort of two things going on here. The functional residual capacity is expanded for the gas, but on top of it, as part of that, the surface area for which gas exchange is actually taking place is increased. And that's one of the reasons why when you apply a PEEP or a CPAP to someone, it improves their oxygenation. Last of all, and though I don't spend a lot of time on this, there's sort of a diffusion constant, which takes into account a lot of different things like solubilities and so forth that also play a role in gas exchange across a membrane as well. Now that you sort of understand these things that are influencing diffusion, we want to talk about another predominant core idea that influences the efficiency of gas exchange. Because it's very easy in your mind to think, for example, the thickening of the membrane, that must be what's hindering most of my COPD patients and so forth. But that's not necessarily the case. There's actually something else that's predominantly overriding the inefficiency of gas exchange in these patients, and I want to talk about that now. So we ask ourselves, Which lobes of the lungs is it most common to see tuberculosis? And you might recall from your studies or from school, we generally see that in the upper lobes of the lungs. We get these tubercules there. And the question is why? Why does that occur? Well, it happens to be very interesting because in bats, for example, when we ask the same question, which lobes of the lungs do we commonly see tuberculosis in bats? It's the opposite. We actually tend to see that this is the bases. The image on the left I have actually taken from a presentation that Dr. John B. West often gives, where he talks about this issue in bats. And we see that in all actuality, they tend to get tuberculosis kind of in their bases. And bats tend to hang upside down. And that gives us our first clue or inclination as to what might be going on here. So it turns out that tuberculosis tends to like very oxygen-rich environments. And the apices in humans tend to have higher alveolar O2 levels than the bases do. In bats, this is often reversed. And so you might think, well, does it have something to do with gravity? And if that's what you're thinking, then indeed you're correct. So we're obviously very familiar with this. This is an image that somebody adapted from West's physiology of the lung. And they sort of suggest several zones of the lung. Sometimes you see this broken up as 3 zones. Sometimes you see this broken up as 4 zones, a theoretical zone up top. But what happens is this. From a proportion standpoint, we get something called ventilation to perfusion inequality. And it turns out throughout the lung, there is ventilation to perfusion inequality, where proportionally there's more ventilation to blood flow in the apices, and there is more blood flow to ventilation in proportion in the bases. And this creates a bit of a disproportionate matchup between the fresh gas coming in and the blood flow through the lungs. So why does that occur, and why would the alveolar O2 level be higher in the apices? It's because if you're bringing fresh gas in, but you have less blood to uptake that oxygen and carry it away, then you're going to have a higher concentration of alveolar O2 in the apices, and in the bases, if you have more blood flow, because gravity is increasing the blood flow to the bases for the ventilation, that is the proportion. I'm not talking about absolute values here. I'm talking about the proportion of ventilation to perfusion. Then the blood is going to be able to carry away more of the oxygen that is in the air that is brought into the bases of the lung. Well, I think it's very easy and intuitive to understand why it is that the blood tends to pool in the bases of the lungs, or what we sometimes refer to as the gravity-dependent regions of the lungs. I find that people tend to struggle more with why it is that ventilation tends to be higher in proportion in the apices. This is not just a matter of less blood flow to the top and more blood flow to the bottom of the lungs, or the bases to be more accurate. It's also a need to understand that if you think of the lung as a conical structure or a cone, it is a pre-stressed structure. That means it has a shape outside of the chest of roughly a cone, and it is stressed or strained to the chest wall, which is, you can think of as a cylinder or a conical structure. And so there is more strain at the top of the lung, where it's stretched out to the edges of the chest wall, and there's a little bit of compression in the bases, where the chest wall is sort of consolidating the tissues inside the lung. And that also contributes to some degree regarding the ventilation distribution within the lung. And it's important to sort of keep that in mind. We're going to talk about some interventions that improve ventilation to perfusion inequality shortly when we talk a little bit more about what's going on in COVID-19 when it comes to pulmonary gas exchange. One other thing to keep in mind when we're talking about gas exchange inside the lungs, this is from John West's Respiratory Physiology, a very common textbook. It's pretty ubiquitous throughout the respiratory world. And here he's trying to remind us of something very important. The alveolar O2 level drops from about 150 when we're breathing room air at sea level to roughly about 100 millimeters of mercury inside the lungs. And when this is sometimes described, even in the literature, the explanation for this oftentimes is simply that this is from the ebb and flow of the air moving into the lungs. That is certainly an important factor. But we also have to understand, as West stresses and points out, that the drop from here to here is also a function of how much oxygen is actually getting into the blood itself as well. And we're going to see that this is heavily influenced when there is ventilation to perfusion inequalities in the lungs. In hypoventilation, that is if we think of this as a tug of war between the fresh gas that's coming into the lungs and the amount of gas that is exchanging with the blood. This is a situation where there's more gas exchanging with the blood as opposed to the fresh gas coming into the lung, and therefore the alveolar O2 level tends to drop a lot lower than we would expect to see. So rather than 100, we'll see it quite a bit lower. Again, this is really important. This type of mechanism was to some degree alluded to in some early theories about what was going on with COVID-19. And again, today we will show that that's probably not likely to be the case. Finally, I want to just point out a couple of things here. We've all learned the 60-90 rule. That is that a 90% saturation correlates with the 60 PaO2. The problem with the 60-90 rule is it only holds true if the oxygen hemoglobin dissociation curve hasn't shifted. And indeed, it turns out that the curve shifts quite readily, particularly in the types of patients that respiratory therapists are often asked to see. There's a number of things that shift the curve. One of the predominant things that shifts the curve is CO2 level. But it turns out there are certainly other things that shift the curve. They include pH, temperature, 2,3-DPG. These things have to be often very extreme to have a very clinically significant shift of the curve. But it's important for us to keep it in mind, and certainly something that we're going to discuss when we start to talk about some limitations of non-invasive pulmonary gas exchange analysis. Non-invasive pulmonary gas exchange analysis is used in a number of areas, not just in the hospital. It's also used in like pulmonary rehabilitation areas and so forth. I just want to stress that these devices are regulated by the FDA, so they've been FDA cleared, and they also are approved for use in the Philippines as well. So a normal oxygen deficit, and remember again that the oxygen deficit is the difference between the directly measured alveolar O2 level in the lungs and the calculated O2 level in the blood. A normal oxygen deficit is about 0 to 10 in you and I. And in patients with gas exchange abnormality, it's quite a bit higher. It can be into the 40s and above. But certainly keep in mind that COPD is a spectrum. These were primarily COPD patients and some patients with idiopathic pulmonary fibrosis. This was published in Chest by Dr. John West and colleagues from the University of California at San Diego. Another study that they published there at UCSD was looking at whether or not maybe these changes were simply due to the fact that the patients, the participants in the patient group were substantially older than the normal subjects. I think normal subjects here were probably medical students that were willing to do anything for a buck. And these were obviously patients that had lived long enough to develop conditions like COPD. And I don't think there were any alpha-1 antitrypsin folks in that group. So they went ahead and they took a look at young subjects versus older subjects that didn't have gas exchange abnormality diagnosed. And here we see that it seems that oxygen deficit goes up as you get older, but still, again, it seemed to stay less than 10. This was also looking at a similar thing, young normals, older normals, and patients together. And this was a very interesting study done by researchers at Duke and the University of British Columbia. Again, they were using our non-invasive pulmonary gas exchange analyzer and trying to take a look at the GPaO2. And just as a reminder, the GPaO2 is the calculated PaO2 level. And they wanted to know how good is this as a method for estimating, for calculating PaO2 under various conditions. And they actually looked at a number of different exercise conditions and so forth. And you can see this image is derived from their results. You can see that it was actually had a very nice correlation, that the bias was relatively low, 1.7 millimeters of mercury. The R-squared was 0.97. But when you look at the data, you can see that it's very tight. Down here, the hypoxemic operating range. You know, the PaO2s and GPaO2s that are like 60 and less, it was very tight. When you start to get up near 100, this really widened out. And the reason why that occurs is actually the shape of the oxygen hemoglobin dissociation curve. As you get very high in the PaO2s, I apologize, as you get high in the PaO2s, this widens out a little bit. And so it flattens out here, and a small change in saturation gives you a big change in PaO2. So keeping in mind this method of calculating out the PaO2, the sicker you are in general, the more accurate and tighter it becomes because you end up on the flat part of the oxygen hemoglobin dissociation curve. But fortunately for us, we don't tend to care as much about differentiating between somebody who's 110 from 100 for a PaO2 as we do differentiating, for example, between somebody maybe 60 versus 50. And so that's just one attribute to keep in mind when we talk about what we see when it comes to pulmonary gas exchange analysis, specifically non-invasive pulmonary gas exchange analysis that we're able to do at the bedside. This has been used in a number of different very robust physiologic models. This one is looking at freedivers, which is a wonderful way to look at what a consolidation / pulmonary edema model looks like. As a reminder, freedivers, this was published by researchers from the University of British Columbia, but these freedivers are single breath hold divers. What they do is they go ahead and they take a single breath and they hold their breath underwater and try to dive to these unbelievably deep distances underwater. And what that does is it consolidates the lungs down. And when they come back up, the lung doesn't uniformly open up. They have a lot of compressive atelectasis. They have a lot of pulmonary edema sometimes. And this study was looking at what happens to their oxygen deficit. Again, the oxygen deficit is that value, the difference between the directly measured alveolar O2 level and the calculated O2 level in the blood. And it just went to show that a couple of things. One, that these levels persist for some time after these free divers come up. And two, that other things, like you can see a picture here of a lung comet, that there seems to be correlations between the number of lung comets we would see on a patient and oxygen deficit. So for those of you that are very interested in critical care ultrasound, this might be of interest to you, but certainly it shows that there is potentially a place for really looking at what's going on with the fluid status within the lungs of patients. So again, the three questions that we're trying to answer is ventilation adequate? We look to the steady state untitled CO2 for that. Is gas exchange efficient? We look to the oxygen deficit, which is the difference between the alveolar O2 level and the calculated O2 level of the blood. And is oxygenation sufficient? Again, that is the GPA-O2 level in the upper left-hand corner of this particular monitor. So why do we care about oxygen deficit? Why do we care about non-invasive pulmonary gas exchange analysis? Why not just use the saturation standalone? Well, here's an example. This is an actual COVID-19 case from the Milwaukee metropolitan area. That's in Wisconsin in the United States. And here we can see that the room air, so keep in mind, these were all taken on room air. The room air saturation for this patient never goes below 90%. And I would say that in my previous practice, especially before the pandemic, I generally wasn't terribly concerned about this patient, especially if their saturation stayed above 90% on room air. But when we take a look at what was actually going on with this patient, we see a couple of really important things. First off, the GPA-O2, so the calculated O2 level of the lung, is continuing to drop, and the oxygen deficit is going up. And you might ask yourself, is this something that's unique to COVID-19? And the answer is no. No, it's not. In fact, what's going on here is that the patient is hyperventilating. And it turns out that if your patient, especially if they didn't have any previous lung history, their ability to hyperventilate to compensate for this hypoxemia was very high. And so they would start to hyperventilate. And that causes a left shift of the oxygen hemoglobin dissociation curve. And that matters because if you get a left shift of the oxygen hemoglobin dissociation curve, it means for a given saturation, you will actually have a lower PaO2. And so that's what's happening here. The PaO2 for this patient is dropping and the oxygen deficit is going up. And remember, the oxygen deficit is a measure of the efficiency of gas exchange, or I should say, the inefficiency of gas exchange in the lungs. And the higher the number, the more inefficient gas exchange is becoming. But even more telling is what's going on between days 2 and 3 for this patient. If we use the standalone saturation, we would believe that this patient is stable. But when we actually look at what's going on, the gas exchange inefficiency is continuing to go up. Therefore, the GPA-O2 is going down. But the reason why the saturations remain relatively stable is because the patient is hyperventilating even further to compensate. This gives me a little bit of pause because it wasn't uncommon in my practice to see a patient every once in a while in the emergency department that was maybe on room air or more often on 1 or 2 liters of oxygen with relatively decent saturations, 92, 93%. I would go up to the ICU, take care of my ICU patients, and occasionally 2 or 3 hours later, I would be down in the emergency department, emergently intubating that patient, and I would say things like they just suddenly decompensated. And the reality is they probably didn't just suddenly decompensate. I probably missed pulmonary gas exchange inefficiency because I wasn't looking for it. I didn't feel that I had a signal for it because I was relying on standalone technologies like standalone pulse oximetry. In this particular case, they thought that they were going to end up intubating the patient, but the patient turns a corner. One of the things you're not seeing in these values is they were intervening for this patient because they had this early warning. The patient, I would just note also, ends up getting discharged with a pretty substantial oxygen deficit, and what I would still say is a low GPO2 in my mind. And this goes to show you that just because somebody may be ready to be discharged from the hospital, it doesn't necessarily mean they have the stamina to, for example, return to work. So I want to talk a little bit about what we actually see in non-invasive pulmonary gas exchange analysis in COVID-19 cases. And I picked this case because it's pretty representative of what we see, particularly in the emergency departments. When it comes to COVID-19, now keep in mind these are patients that have not yet decompensated to the level where they need to be emergently intubated. These are spontaneously breathing patients. But we ask ourselves about those three questions. Is ventilation adequate? Is gas exchange efficient? And is oxygenation sufficient? When we take a look at the Untitled CO2 here, we can say, hey, ventilation is certainly adequate. In fact, the patient is hyperventilating. Then we go ahead and we say, is gas exchange efficient? This gas exchange and oxygen deficit of 61, particularly in somebody with no history of previous lung disease, is extremely concerning. They essentially have the gas exchange of a pretty severe COPD patient at this point. And we look to the GPO2, and we see that they have a very low PaO2. In fact, calculated PaO2. In fact, when we use the 60-90 rule, we would expect this patient to be somewhere in the low to mid 60s, but they're already at 57. Again, not crazy COVID physiology, just what we would expect to see due to a left shift of the oxygen hemoglobin dissociation curve. A couple of other points worth noting here on this COVID case, because this is such a common presentation and it's something for you to keep an eye out for. When we take a look at this respiratory rate, it's relatively normal. Some might say, well, 18, 19 is a little high. But when we look at the Untitled CO2, we would say, wow, this is a relatively normal respiratory rate. It seems unusual to see an Untitled CO2 that low. What might be going on here? Well, one of the things that you might be thinking about right now is the patient maybe just taking really deep breaths? And absolutely. That's a very common characteristic as a sign of compensation in these patients, particularly if they didn't have underlying lung disease, because they could compensate at a relatively low respiratory rate by simply taking a deeper breath. And that goes to tell you a few things. That this patient is taking very deep breaths, they're blowing down their Untitled CO2, and a couple of things to be wary of or cautious about. You know, we had several hospitals that were going around saying like, wow, after we implemented the monitoring, it made drastic reductions, drastic improvements in the number of patients going to the ICU or suggesting that it reduced mortality. But we need to take a pause when we hear things like that, because monitoring doesn't save anyone. And I'm going to say that one more time. It's really important to say monitoring doesn't save anyone. It's what you do in response to the information you're provided. And that's really important here, because keeping in mind that if you have a patient that is hyperventilating significantly, and although this measurement is taken on room air, if you're seeing this hyperventilation with the oxygen engaged as well, this is a concern. If you were to put this patient on BiPAP, and think about what's going to happen in this case. If you place this patient on BiPAP and you blow down, what's going to happen to the Untitled CO2? Well, it's probably going to go lower. And if the end tidal CO2 goes lower, what's going to happen to that left and right shift of the oxygen hemoglobin dissociation curve? It's going to shift further to the left. If it shifts further to the left, what's going to happen to the PaO2? Well, the PaO2 is going to drop. If the PaO2 drops, what's going to be the response of the patient? Well, the patient's probably going to try and take even deeper breaths. And now we have a positive pressure being applied to the airway. This should give us pause because that could create some very high transpulmonary pressures. So a cardinal sign that you might be putting the wrong patients on BiPAP, or that you should be cautious about the patients that you're applying BiPAP to, would be if you start to see abnormally high rates of barotrauma, pneumomediastinum, pneumothoraces, right? These are cardinal signs that maybe you're applying BiPAP to patients that are already hyperventilating, and you could actually make things a little bit worse, especially in the setting of an oxygen deficit. Okay, so keep that in mind. These patients are ideal for things like high flow oxygen, for CPAP with high concentrations of O2. Keep in mind, there is a place for BiPAP in these patients, particularly once they've gone into respiratory failure and you start to see that CO2 climb. And I think that some might even make the argument that by the time you see that CO2 climb, it's kind of late for non-invasive intervention at that point. We've been learning a lot during the pandemic, but I'll just simply leave it at the fact that you want to be cautious in these patients, that there may be an argument that high flow oxygen and CPAP may indeed be better for somebody with a presentation like this, where they appear to have a strictly hypoxemic respiratory failure. Perhaps BiPAP isn't the best modality for them. There's some considerations to keep in mind when you're thinking about that. But here's an example of a patient that you don't need non-invasive pulmonary gas exchange monitoring to recognize that they're in trouble. Here we can see this patient indeed is hyperventilating again. They have a huge oxygen deficit. They've got a low GPaO2, but even their saturation is extremely low. They have a very bad PF ratio down here as well. We take a look and we can see that even the respiratory rate is quite high. So it would be very evident that this patient is struggling. But the reason why I wanted to show you this was twofold. One, this is a perfect example of a patient that is very late to intervene on. And that can be a real challenge when you get a patient that's this sick. The idea is we hope to try and intervene here. Intervening here is going to be much harder. The other thing I wanted to point out, to contrast to some of the things that we talked about earlier, the alveolar O2 level in this patient is elevated quite a bit. Remember, we said like ideal would be like right around 100 or so. There's two things going on here. Certainly, this is a high respiratory rate, and I think that it's fair to assume that there is a higher rate of gas when we think of that tug of war. There's a higher rate of this gas coming into the lungs. But on top of it, there's this challenge of getting that oxygen into the blood. And that kind of causes the alveolar O2 level to sort of back up and increase inside the lungs. So both of these forces are contributing to this. And I think that this is a perfect example to sort of see that what we aren't seeing is a lower alveolar O2 level that one might suggest is more reflective of something like you would see in high altitude. So again, I want to reiterate this point. It can't be stressed enough. Monitoring doesn't save anyone. It's what you do in response to it. Here is a protocol that I refer to as the Milwaukee Protocol. So there are about 5 hospitals in the Milwaukee metro area that are using this. I just want to be clear. This is not a protocol, for example, that came from MetaPines, and we don't endorse any specific hospital protocol. but this is a really good, this is just being provided for educational purposes, and this is a really good example of how you can utilize non-invasive pulmonary gas exchange monitoring in an actual workflow to try and change the outcomes of patients. So here, if the patient was COVID-19 suspect or positive in the ED, the respiratory therapist took the AGM measurement on room air. And keep in mind, as you saw in the video that we played in the beginning, the patient just breathes on the breathing circuit with nose clips on and has a pulse oximeter on their finger. These tests usually provide results in under 2 minutes. And if the O2 deficit, which is that difference between the alveolar O2 level in the lungs that's directly measured in the calculated O2 level in blood, is greater than 40, or if the PF ratio was less than 300, they would go ahead and they would prone that patient and administer high flow oxygen irregardless of the saturation, right? They had a saturation cutoff as well, but even if the saturation was good, if they met either of those criterion, they would go ahead and they prone the patient and they administer high flow oxygen. What's interesting about that protocol is what they would do is they would take a measurement before and after proning. And again, this case is sort of selected by the facility, one of the facilities. This patient was picked because they were a responder. I want to be very careful here so that you understand that not every patient that you self-prone is going to respond in this way. But the patient actually, ventilation was adequate, but they had a pretty decent oxygen deficit. So gas exchange was impaired. Impairment was high. They had low PaO2 and a GPaO2, the calculated PaO2 level, and their PF ratio was relatively low, 279. So just keep in mind that depending on what's available on the X-ray, 300 is the current cutoff by definition for mild ARDS. Moderate ARDS is 200, and severe ARDS is less than 100, right? About 3 hours later, they take a repeat measurement. Again, they take the patient off the oxygen in order to do this measurement, and we let everything sort of reach steady state. And we can see that the end tidal CO2 actually goes up a little bit. I'm going to talk about that in a minute. But that the oxygen deficit, that is the difference between the alveolar O2 level in the lungs and the calculated O2 level in the blood, it drops dramatically. And more importantly, the GPaO2 level, that is the calculated O2 level in the blood, goes up quite a bit. The saturations and the PF ratio have both improved. So this shows you that this patient is a responder, and that's very useful, particularly if this patient goes downhill later on and they're up in the ICU and there's this question about whether or not we should consider proning the patient. It's nice to know, to have that piece of information that they were a responder before, because interventions come as a package. And while there are some good benefits that may come to some patients with proning, there's also a lot of things that we're kind of wary of that also come along with proning. And so having this information can help aid in that decision making. Now, one question I get sometimes is people say, well, what happened to the end tidal CO2 here? Why did the CO2 go up? And that's a great question. You know, one of the reasons why proning helps is we're able to improve ventilation to perfusion inequality. Remember that slide earlier where we talked about the fact that blood was gravitationally drawn to the bases? By going ahead and proning the patient, you go ahead and moving them from a supine to a prone position, you're able to take advantage of moving some of that blood to sort of the apices of the lungs. But in addition to that, there's a mild level of sort of improvement in distribution of ventilation throughout the lungs. But what happens as a result when you move from supine to prone position is you don't get as much chest excursion, or at least the compliance of your chest is reduced. Because now instead of having your sternum facing up, now your spine is the section that is facing up, and it doesn't have as much give to it. So you will see sometimes that there is a little bit of an increase in CO2, and I really feel that that's probably what's happening here. There's some other things that could be going on as well, but this is the most likely thing, is that tidal volume to some degree has been reduced, but the patient isn't terribly responsive to it because they've sort of overcome this hypoxemia that they had earlier. So that is sort of a great example of being able to take a measurement pre and post. Another thing to keep in mind when we're talking about the implementation of pulmonary gas exchange analysis, non-invasive pulmonary gas exchange analysis to be specific at the bedside, is as respiratory therapists, how do we integrate something that provides us such detailed information so quickly into our actual practice? And one way that we do that is through the use of protocols, for example, that or algorithms that help guide the kind of care that we deliver. So, for example, let's say that we were in a post-operative setting, and you saw that a patient had an oxygen deficit of 22. This patient probably would not receive very aggressive bronchial hygiene or lung expansion therapy. And then based on our assessments and the values coming from the machine, if we saw that they're in the lower 30s, you would probably use something a little less aggressive, but something like an acapella or an aerobica. If you had a patient that was quite a bit higher, you might be starting to think about what modalities you have available to you. Something like an easy PAP or a metaneb, for example, might be appropriate in your facility. When you start to see really high values in patients, particularly if they don't have a previous history of lung disease, this could be your real warning sign. Now, this happens to be the exact case that we were just looking at, so I happen to know that this patient is COVID-19 positive here on the right with their oxygen deficit of 61. But again, you'd be thinking about, if this was a post-operative patient, you'd be thinking about what's going on with the fluid status inside the lungs. Should I be using a positive pressure modality, for example, like CPAP in this case, because the end-tidal CO2 is relatively low? Do I need aggressive bronchial hygiene therapy? Taking a look at how the patient is doing. Is it time for imaging? What's their fluid balance, etc.? These are all the kinds of ways that we integrate non-invasive pulmonary gas exchange monitoring, which is looking at the primary function of the lungs, right? It is gas exchange. But we look at that primary function of the lungs, and then we try to see what is it that we have in our toolbox that can help us out. Because in respiratory therapy, oftentimes it's not about having more tools in your toolbox. It's about knowing when it is I need to use which tool. And that's one place where non-invasive pulmonary gas exchange analysis can be very useful. This is an example of a protocol. We've got permission to share this protocol from a facility. And here you can see that they actually change based on the deficits. They'll actually change their saturation targets based on what they see. So if the O2 deficit's over 40, they actually change the saturation target for the patients to try and avoid the complications that are sometimes seen in left shifts. And then they also reference a separate COVID protocol that they have. So a couple of things to keep in mind. We've talked about the different things that we might see in various disease processes when it comes to a non-invasive pulmonary gas exchange analysis, but I think it's very important for you to understand the limitations. The way that we are getting the GPO2 is we're taking your saturation, we drop you on the oxygen hemoglobin dissociation curve, and then we correct the curve based on your steady state end-tidal CO2. This is a very effective way of doing this, but it has its limitations. And it is as important as anything. As important as knowing when to use it is when you probably should not be using this. So for example, in patients that have suspected carbon monoxide poisoning, the saturation is no longer going to be reflective of their oxygenation per se. And so you would not want to use this in someone that you're suspecting has carbon monoxide poisoning. The other thing is, although CO2 is one of the predominant factors that shifts the oxygen hemoglobin dissociation curve, as I alluded to earlier, there's other things that shift the curve. And if they are very severe and substantial in nature, you must take that into consideration. So, for example, if you're suspecting a severe and strictly metabolic alkalosis or acidosis, this methodology is probably not the best methodology to use. It could lead you astray a little bit. So, for example, in the patient where you might be suspecting initially in the emergency department that they have a major metabolic ketoacidosis, right? In that case, you would want to get some measure of acid-base balance, because one thing you don't receive currently in non-invasive pulmonary gas exchange analysis is any indicator of what the acid-base balance is, right? So you'd want to get at least a VBG to get a look at the pH. Maybe you'd grab an ABG as part of your normal protocols to get a look at the pH. As soon as you can see that that pH isn't very extreme in one direction or the other, then you would know that you can actually go ahead and continue to use non-invasive pulmonary gas exchange analysis, but keep that in mind. For that reason, among others, we would say that this is not considered a complete replacement for an arterial blood gas, for example, because you don't receive that acid-base balance with it. But there certainly are plenty of times where we're trying to just get an understanding of what's going on with the patient's respiratory status, and acid-base disturbances aren't a concern, and carbon monoxide poisoning, for example, is not a concern with the patient. And these would be cases where you would go ahead and you would get that. Of note, for the carbon monoxide poisoning, you don't just want to grab an ABG. You want to make sure that you get an arterial blood gas with co-oximetry in that case. This is a point to stress. The other thing to keep in mind is that currently this is required, it's FDA cleared to be used in patients that are spontaneously breathing. So we don't use this in patients currently that are intubated. When we take the measurements, we take these patients, if they're on oxygen, they take them off their oxygen to get these measurements on room air. And there you have to use your clinical judgment. We tend to see that once a patient's on high flow of 50 and 50 or greater, it's become pretty challenging to take these measurements. So there is some level of limitation there. They need to be able to come off their oxygen in order to reach steady state for usually at least a couple minutes. There are ways to sort of end the test early, but then it can be a little bit difficult to interpret the results if we aren't sure that they're in steady state. So that really describes how these respiratory monitoring systems that utilize pulmonary gas exchange analysis sort of work by giving you non-invasive PaO2 and alveolar O2 measurements in order to go ahead and calculate out the difference between the oxygen level in the lung and the oxygen level in the blood. And we refer to that as oxygen deficit. And oxygen deficit is the best indicator of pulmonary gas exchange inefficiency. And we often use it as a surrogate for VQ mismatch. And so with that, I would just go ahead and thank you for the time to be able to speak with you. And we know the challenges that you're facing at the bedside, particularly during this pandemic of severe hypoxemic respiratory failure. And if you do have questions, you can feel free to reach out to me. I flipped through some slides, which was just a nod to some of the influences in my life as teachers and so forth, but I haven't really asked for their permission for it to be included in the particular presentation that's being recorded, so I just sort of flew through those. But again, feel free to email me or reach out to me if you have questions. And this technology is available in the Philippines.
All right. Thank you so much for this great presentation, Mr. Hinds. Thank you, thank you.
Yeah,
And
absolutely.
yeah, and for our audience, if you guys have any questions, please do reach out. Um, and hopefully, Mr. Hinds, can answer your question. Sometime when he's available. Again, thank you so much for presenting today and being a guest for our today's episode, our show. Thank you so much, Mr. Hinds, and we do appreciate you. Please stay safe and hope to see you again on our one of our episodes in the future. Thank you so much, and this will greatly help our colleagues in the profession. Thank you so much.
Absolutely. You as well, Michael.